So in my previous talk, I emphasized that the importance of the laxity pattern of smaller medial than lateral. So we should avoid intraoperative Valgus gap for medial pivot TKA. So my next topic is about the causes of the Valgus gap pattern in TKA for medial knee osteoarthritis. So COI is described in this slide. So generally, a medial knee OA has a varus alignment, medial tightness, and lateral looseness. Our surgical procedure consists of the minimal soft tissue release and the removal of osteophyte and accurate osteotomy based on the anatomical landmark. So most of medial knee OA have been reported to have lateral laxity, so we consistently accept lateral laxity. However, all these concepts are based on the premise that all the osteotomy are accurately done. As osteotomy errors are inevitable in TKA, the combination of the osteotomy error in femur and tibial may induce the valgus gap. It automatically progresses. Yep. So sorry about it. Regarding the factors that affect the intraoperative gap angle, preoperative factors consist of alignment, deformity, and soft tissue property, or intraoperative factor consists of soft tissue releases and amount of bone resection. However, it has been not clear how the osteotomy error influenced the intraoperative gap angle. So we hypothesized that the osteotomy error affects the intraoperative gap angle in TKA for medial OA, and examine this hypothesis in this study. Subjects are 100 knees that undergone TKA for medial knee OA, as the number of males were very small, so we excluded the male patient. We used the evolution medial-pivot knee for all cases, and the target alignment was shown in this slide. Surgical technique was exactly the same as my earlier presentation. The important point is that the minimal soft tissue release were the maximum effort for accurate osteotomy, and gap controlling with the priority of the medial stability. For the intraoperative gap assessment, set the femoral trial after completing all the osteotomy and apply the traction force by 150 Newton in knee extension and 90-degree flexion. Then the extension gap angle, EGA, and the flexion gap angle, FGA, were evaluated. This slide shows how to evaluate the bone resection error. Firstly, the post-operative implant alignment was three-dimensionally assessed by knee cast system, which was utilized 3D to 2D image matching technique. We evaluate the combined combined resection error, CRE, which was the sum of the femoral and the tibial resection angle error. The CRE in knee extension and flexion were evaluated. Those were ECRE and FCRE. The relationship between ECRE and EGA and FCRE and FGA was statistically examined. This slide shows the result of gap angle. The mean EGA and FGA were 3.1 and 2.5, respectively. As shown in this histogram, almost all knees show the various gap angle, except for only one knee, which showed the 1 degree valgus in knee flexion. This slide shows the result of CRE. The mean ECRE was minus 1.2 degree, which means a slight valgus angle, while that of FCRE was 0 degree. So, 0 degree, although the deviation was a little bit greater than that of ECRE. The absolute error of ECRE and FCRE were 1.9 and 2.6, considering that those values include the errors in both femoral and tibial side. The bone resection error in this series were quite low. Being different from our hypothesis, E and FCRE showed no significant correlation in this series. One previous study investigated the relationship between the bone resection error and gap angle. They radiographically investigated the combined resection error, which is the sum of the femoral rotation and the tibial varus valgus angle. And post-operative flexion gap angle. And they demonstrated the significant correlation which disagree with the result of our current study. In this series, also being different from our study, valgus gap was showed in 8.6% of knees. They concluded that the femoral rotation positioning might cause the valgus gap. However, the range of the combined resection error of the knees that shows the valgus gap is not greater than that of our study. Therefore, we consider that the soft tissue releases might magnify the effect of the osteotomy resection error in their study. Okay, so in this study, the osteotomy error, which theoretically affects gap angle, even showed up to 7 degrees of valgus gap pattern, and slightly valgus gap pattern on average. Intraoperative gap angle was varus in most knee and slightly varus on average. So considering that osteotomy error did not correlate to the gap angle, the amount of osteotomy errors in this study with minimal soft tissue releases neither possible causes of the valgus gap pattern are thought to be unnecessary medium releases rather than osteotomy errors. In summary, osteotomy errors within the range of this study did not affect that gap angle. The impact of the soft tissue releases on the intraoperative gap angle was thought to be greater than that of the osteotomy errors. However, further excessive osteotomy error may affect the gap angle and causes the valgus gap angle. So the message of this study is we have to be very careful to the medial soft tissue releases for medial-pivot TKA in the medial knee OA. Thank you for your kind attention.